Welcome, welcome. A very warm welcome to panel 2. We are just bringing our speakers into the room now. There we go. Welcome, Bernice, Christina, Lena. Lovely and Disquette, lovely to have you with us. So this is Reimagining Community-Centered Mental Health Care. This is all part of this first set of panels, the first 2 panels. And it's my honor to be able to moderate this session with you. When we met before and planned the session, we thought we would do a little thing, which is to invite each of you to jump in first, not all at once, of course, and just introduce yourselves, introduce your name, and a little bit about your organization. So that's what we're doing today. We have 3 organizations present. We have the Friendship Bench, we have Colors of Connection, and Man Talks. These are all organizations which have a great deal to say and to do when it comes to the whole question of culture and mental health, as much as anything else. Lena, can we invite you to jump in and say a little bit about Friendship Bench and of course yourself as well?
Sure. Good afternoon, good morning, or good evening to all the attendees and also to the panelists. Thank you, Chris. My name is Lena Zamchia, and I'm the Chief Operating Officer with Friendship Bench. Like Chris has mentioned, we're in the business of mental health, and our mission really is to get people out of depression. And so we are a Zimbabwean-based not-for-profit organization that has been in the mental health space since 2006 and really derived from our founder and CEO, Dixon Chibanda, who, encountered an issue around suicide. And because he's a psychologist, was prompted to initiate an idea to address issues around mental health and really look at the last mile in terms of access. And so our vision as an organization is we envision having a friendship bench within walking distance for all. So hence the issue of access to the last mile. And ours is a cheap, no cost, free intervention that community members are able to access. It's indigenous in that we use non-traditional approaches. And so we're really disrupting the mental health space by utilizing what we know as grandmothers. And, grandmothers, lay health workers or community health workers or cadres who deliver the intervention after being trained by our team through problem-solving therapy. So we really like to utilize and address the intervention as talk therapy, where we're trying to demystify the concept around mental health and really provide access to community members that are at the bottom of the pyramid. Our organization is evidence-based, and so we're rooted in research, and our values really stem around empathy, connectedness, and being anchored in research. And so the grandmothers deliver the problem-solving therapy on a wooden park bench, and we're associated with primary healthcare clinics around Zimbabwe, and we've actually scaled into the 10 provinces in Zimbabwe. So that, in essence, is a nutshell about who we are as an organization, Zimbabwean-led, and an unconventional approach to providing mental health therapy to community members at large. Thank you, Chris.
Thank you, Lena, very much indeed. And now let's turn to you, Disquette. Do please jump in, tell us a little bit about the organization and what it does and yourself.
Thank you, Chris. My name is Disquette, and I run a mental health initiative in Mumbai, India, called Man Talks. The idea and the foundation of Man Talks really began with a vision to make quality mental health support accessible and affordable to communities in India. The focus was to make sure that we're serving underserved communities, whether they're individuals from low-income groups, communities that have been marginalized over generations, and to make sure that they had access to quality mental health support. Now, Montauk started in 2020 when we were in the middle of a global pandemic. And we were already in 2017-18 reading reports that said that the incidence of common mental health conditions in India was extremely high. And, reports were saying that every 1 in 7 Indians could experience depression, generalized anxiety disorder. And we know that the pandemic only made it worse, right? So with limited access to physical resources, with people being locked up, with human connection being sparse, the first thing that we started with was a telephone-based intervention where we set up a tele helpline so that everyone that has access to just a telephone could reach out for mental health counseling. So with the help of a team of psychologists, we started providing free mental health support via telephone. And the way that the telephonic intervention was structured was that if someone calls us in crisis, of course, we would provide immediate crisis intervention. But if someone calls us in a non-crisis situation, the phone call was structured like a regular therapy session was. And it was absolutely free of cost. This was a model that picked up really well in the pandemic because it was the need of the hour. There was immense loneliness amongst individuals, a lot of anxiety, health anxiety, death-related anxiety, a lot of increase in depressive episodes. So this model worked really well for us in 2020 and continues even today. From there, we started expanding our service delivery into free email counseling support, again, to all individuals across the board for free, and then expanded further into appointment-based therapy, which was also accessible to everybody in a couple of languages, but was paid, though highly subsidized. So every session with a dedicated therapist will only cost you $5, and you have access to your dedicated therapist for long-term therapy. Apart from the direct services delivered to beneficiaries, one of the larger visions with which we began Montauk's was to work on the larger preventive promotive model of mental health care, because the incidence of common mental health conditions is so high in India that the requirement for professional support is only getting larger and larger, and the treatment and care gap is immense. So specifically in urban India, where again common conditions like depression and anxiety are 20 to 40% higher than rural parts of India, our focus today is to make sure that we're raising awareness, having open conversations on mental health, trying to reduce stigma, hosting a lot of group engagement, workshops, support groups to bring people together in person in urban India and virtually across the country, to just make sure that conversations are happening without being stigmatized. And one of the niche beneficiary groups that we're working very closely with are caregivers, because again, we feel like if you're caring for someone that's dependent on your care, that also does put you at a high risk of developing a mental health condition that would then require professional support. So as part of our larger preventive model, we're working very closely with caregivers to provide them safe spaces to build a community and get mental health support. There are a lot of other programs we run, but
let me leave you there.
Stop.
Yeah, that's great. That's really helpful to have a sense of what you do. Christina, please come in.
Sure, thanks. I'm the co-founder of Colors of Connection, and my background is in the arts. I studied painting, and from a young age was always very engaged with drawing and anything creative, and moved into the nonprofit space, wanting to make creative expression more accessible to young people who had maybe experienced high incidence of trauma. And in my own experience as an adolescent and working through challenges was that I could turn to the arts, and even when I didn't really know exactly how to articulate what I was processing, and I found it to be very helpful personally. So that's been the driver of my work. And currently Colors of Connection works with adolescent girls and young women in Eastern DRC. It's an area that's quite insecure, and we work in Goma, which is an urban region, about 1.5 million people. And our target population are girls who are at the cusp of adolescence, age 10 to 14. And what we're doing is providing safe spaces and mentorship for the girls through weaving together both creative activities and foundational life skills, and wanting to support their social and emotional health and mitigate trauma. And currently we're working with about 300 girls, 8 young women mentors who deliver the sessions, and 150 parents and other community stakeholders. And just sharing a little bit about our creative approach, and we do public mural making. We also do discrete creative activities in groups. But what these look like are activities that come from a range of mediums: drawing, painting, sculpture, music, and they could be anywhere from 5 minutes to 45 minutes. And we drew from different resources, including art therapy, but also local artists, international artists, program staff to put this together. And I just wanted to share some of the things we thought about to make this a more accessible resource for young people in these environments. One was thinking about the cost of materials, wanting it to be low resource. Also thinking about activities that could be easily taught and passed on to others to help with scaling efforts. And less focused on developing a technical skill, which is sometimes associated with the arts, and more focused on expression. And lastly, being trauma informed, so paying attention to not triggering further trauma based on the setting that we're working in. And I think I'll just add one other thing, which is that we've been thinking about mental health assets and what this work can offer for mental health. And one that I think is very interesting is this the imaginative capacities that are supported and nurtured through creativity. So looking at how creativity supports the ability to imagine different futures and identities beyond restrictive gender roles, which is hugely important for girls who are in this environment where their social position is highly restricted and they need to have that capacity. And creativity has been found to be able to resuscitate imaginative capacities when there is trauma and damage from trauma. So yeah, I think that's one of the attributes. We think that it can be utilized much more in the field and hope that it will be in the future, and are planning to scale up over the next 3 years in the city of Goma, staying with a high density model so that there's peer support, and hopefully reaching up to 3,000 participants.
Thank you, Christina, very much. Bernice, you're very welcome. You are part of the team with the Friendship Bench. I think you're the clinical manager or director, am I right?
Yes,
you are.
right.
There we are, good. I was saying you were going to be on mute. Would you like to, anything you'd like to contribute to what Lena has already said before we jump into the main part of our conversation?
No, I don't have any contributions. She said it well.
Okay, that's great. Thank you, Bernice. You're most welcome, by the way. Thank you very much, all of you, for giving us this first round of a description of the organizations that you represent, their backgrounds. And my goodness me, when you think about it, we have, on the surface, we have very different approaches, very different models, which are each are effective and working in their own way, but so different, which is so interesting. I wanted to start to think about the effect that you have on the community with your models. In other words, I'd like us to sort of edge more gently towards this whole question of culture and mental health, which I think is really important. Lena, if you'd like to kick us off on that one, what do you think the consequences are of the community becoming involved with the grandmothers with the community, that whole relationship that you described very accurately before. How do you think it affects the community itself and the culture within?
Thanks, Chris. It really impacts the community just in terms of community ownership and buy-in. And the relationship is also important with regard, especially with regards to mental health. There's issue around stigma. And so because we've identified the grandmothers as the delivery agents for task shifting around the mental health intervention, it's important for us to know that grandmothers are highly respected in communities. They're the nurturers, they're rooted in the communities, they are, they shared wisdom. And so by being upheld in the communities, it's much easier for a client or a beneficiary to engage in a conversation around some of the problems that they're encountering. So hence the idea of problem-solving therapy. Also, they are able to go into the communities and provide psychoeducation. So culture becomes key in terms of recognizing that the grandmother is symbolic to be able to assist in addressing issues around mental health. But also the uniqueness with the French bench intervention is that the use of the vernacular, where we've been able to translate certain terms to ease the understanding around, mental health. And so lighten the load, lighten the burden or the understanding, and also demystify issue around stigma. So we use certain terms around kufungisisa. There's Shona terms, so we use kufungisisa, which means overthinking. And, when a grandmother or the community health worker speaks to a client about kufungisisa, it really opens up the mind around, I have been overthinking about several issues. So it could be issues to do with economic challenges that they're facing in their communities or their home environment. It could be intimate partner violence that they're facing. And so by understanding that kufungisisa, my mind is overacting or it's overthinking, enables them to then initiate a conversation about, what is it that how can I be helped? And so we also then term issues around kuvura fungwa, which means opening up the mind. So once you've identified that you've been overthinking, we then look at opening the mind with the client, so what is it that is actually challenging you? Or what problems are you encountering? And then we then go into a process of uplifting, which is kusimudzira. So just that idea of localization in terms of using local language to enable ease of resonation in terms of how people can then access mental health services has really been a unique opportunity for us to, spread the intervention within the Zimbabwean environment. And, Bernice can actually even share additional concepts around culture, why culture is important and unique in just supporting issues around mental health.
Bernice, did you want to jump in on that very point?
Yes. So most of our grandmothers, some of them are involved with the Ministry of Health, and they are health promoters. So these grandmothers, besides being highly esteemed, they are also involved in other activities, health promotion activities. So if there are any outbreaks, disease outbreaks in the communities, they educate the public on how to prevent diseases. They talk about nutrition. They also teach about nutrition. They are also leading some of the livelihoods programs. So on top of the duties that they do in the community, there is also the mental health aspect. So they also go into the communities, they talk about mental health, they do problem-solving therapy with clients, and all this is rooted in activity scheduling, behavior activation, and problem-solving therapy. So besides us having grandmothers, we also have the youth component, because we realize that some of the youths were not going to grandmothers. They preferred talking to their peers. So we've added that component also on top of the classic grandmother giving sessions. We've also added the aspect of the youth. They give sessions to their peers because some youths are comfortable doing sessions online, and sometimes grandmothers can have challenges having sessions online. So we also have trained youths, we've trained students in universities, because sometimes grandmothers may not be able to reach the population in university. So we've just tried to diversify our means of offering the problem-solving therapy so that no one is left behind. And also our intervention has also applied in all settings. For instance, we've trained grandmothers in the rural settings. We've got grandmothers in the urban settings. We've got grandmothers in the peri-urban settings, meaning that this intervention is applicable to all settings in our culture, all communities in the culture. And also, we've noticed that like if we combine what grandmothers are doing, what the youth is doing, what the online community is doing, it will help in trying to lessen the treatment gap when it comes to mental.
Yeah, so you're getting to that place, which is a great place to get for an organization where you've got volume beginning to actually work in your favor, which is fantastic. Thank you, Bernice. Disket, the major, you have a number of programs, as you mentioned earlier, but the major one, of course, is the one is online. It's actually phone, in fact. Am I right?
Yes.
And in which case, you have people phoning you from not only your own state in India, but many states in India. So therefore, you're dealing with volume from time to time. How does that affect the way you work? And how does the cultural question then come into that?
Right. Currently, we get calls from every Indian state. And as most of us know, India is extremely diverse when it comes to culture, when it comes to language, when it comes to religion, food. So the fact that we're such a diverse country, I feel like works in our favor sometimes, but gets very challenging, especially when you're delivering a mental health service that is accessible to every individual across such a diverse country. So I think some of the things that we prepared ourselves for through training of the team was to make sure that all of us understand that it's important to understand the cultural context of every client that reaches out to us and invest time in understanding where they come from, the way they've grown up, and to truly understand their local context before going ahead with the mental health interventions. Because again, we do have a diverse team, but no team, I think, can be diverse enough to address every part of India because it's so huge and so diverse. So I think one of the things that we do is to just spend enough time with each client to understand their context and then deliver interventions that are more contextualized to where they come from and how they've grown up in life. So I think that's something that we've been able to do over a period of time now, but it's something that you have to consciously work towards. Even language is quite a barrier because, again, different parts of India speak different languages. Every state has multiple dialects. So to deliver therapy in a language that's not even your second language gets very difficult, and therefore we do provide therapy via different local languages. But when there is a caller that doesn't speak either of these languages, then that definitely faces more challenges for us.
And the people who answer the phone and who are therefore the first line of communication and therapy, how do you train them to cope with that? Because that must be a really important and significant factor in Man Talks.
Absolutely. our benefit is that every member that speaks to clients on the helpline is already a psychologist that has a master's degree in counseling or clinical psychology. And thereafter, depending on their years of experience, we put them through a rigorous training program to just improve upon the sensitization. But I think what does end up happening is, because we're a helpline and there are a lot of crisis situations, there are so many diverse cultural contexts of every caller from different parts of the country. We have active sessions within the team to debrief each other about long-standing client cases, so that we're also sharing ideas. Again, every team member comes from a different part of the country and they can share their own personal experience, and they're exposed to different cultures as well. So there's a lot of cross-learning within the team, and a lot of supervision structures internally to make sure that each individual is equipped with the right amount of tools and has a requisite amount of time to read, to upskill themselves as well. So we're very conscious of the amount of time they spend with clients versus the amount of time they spend to have internal discussions, take supervision, do their reading, do more discussions to just stay more equipped with context.
Mm-hmm. Thank you. Thank you very much, Disket. Christina, when we're talking about art, the word culture sometimes feels almost redundant because, of course, you're right in the middle of the application of culture. But nevertheless, how does it play out with the young women that you work with in Goma particularly? How does that whole question of applying the art on the one hand, doing the mural or the joint painting, whatever it may be, on the one hand, and on the other hand, the cultural context of the people there. I think I remember thinking when I was looking at your work before, I was wondering whether the people were from, in fact, Goma, or whether they were people who would come in, as many people have, having been displaced from outside. So all of that would affect the way in which they dealt with art and culture in itself.
Yeah. Well, the people that we work with are based in Goma and have grown up there.
Right.
They're not displaced. And I think it's sort of a dance between, I mean, one of the advantages of working through a creative approach is that creativity really does exist everywhere. And so there's always an opportunity to build on indigenous practices.
Mm-hmm.
In the case of where we're working now, at the same time, some of those practices have been sort of suppressed through colonial history, perhaps are not very well understood, and some practices are, for example, maybe not the most accessible or most supportive of young people. And so it's been about bringing in, we have brought in practices that don't exist, like, for example, the public mural making in Goma, and, different things. But then I think at the same time, drawing in and having a mix of activities is really important. One activity that we do that is sort of a representation of that mix is like a collaborative mandala, where participants will bring material from their home and together create a mandala in the space. And so there's a connection between their own context and also, this idea has come from somewhere else. But I think it's very important to always have that balance, and so that there's that feeling of ownership and connection that the participants have.
Thank you. Lena, would you think that would it be true to say that and listening to all of the different descriptions of the models we've heard from Disket, from Christina and your colleague Bernice, would it be true to say that all of the organizations we're thinking about today provide safe spaces, but in different ways? Does that strike you as something that we could agree on, Lena?
Certainly. I think it is. Safe spaces are important because, it opens up the opportunity for one to feel comfortable in engaging in talk therapy and not feel condemned or judged and also addressing the issues around confidentiality, which are really key, especially for somebody who's wanting to, understand the why around the challenges that they're facing aligned to mental health.
Absolutely. Absolutely. How do you see that, Disket, the whole question of safe spaces? Because people ringing in must, on the one hand, expect some kind of safe space, I suppose, and confidentiality, as Lena has just mentioned. And on the other hand, they may, they're talking to someone they don't know. And so there is a kind of strange anomaly there, isn't there?
Yeah, I think it's very interesting because on the tele helpline, you're speaking to a complete stranger. But also we've seen that there is a certain sense of comfort when you're speaking to someone you don't know. And therefore, we really promote speaking to a therapist who's not someone that you've known personally. And therefore, you could have extremely open conversations with them and not fear immediate judgment. So I think for us, we've tried to create a space where individuals who may not know us are comfortable enough to speak about the most vulnerable of topics. I think the topic of mental health itself in India has been so stigmatized and is still quite stigmatized that people aren't able to openly speak about experiences where they could truly benefit from professional support. And therefore I feel like spaces like helplines that do give you invisibility, because we don't require clients to disclose their identity when they speak to us, provide them that sense of comfort that that they have some invisibility and they can be open about whatever they're facing. So I think because the topic of mental health has been so stigmatized and a lot of conversations are just never had, the fact that someone's listening to you without judgment itself is such a safe space for so many callers. And I think that's been a sentiment that we've we've sensed since day one of Mun Talks, that people are so happy to just have someone listen without judgment and to kind of provide them that space to be truly, truly vulnerable. So I think a virtual safe space in itself is such a blessing to so many that have not had that space, even in their most, in their most like close relatives or friends or personal spaces.
Thank you. Christina, how does the sort of safe space thing work with you? Because you have your people there, they're painting, they're working in groups quite often. How does that work through them?
Well,
in terms of the
I guess,
provision of safe
there's
space?
two different, when we're doing public mural making, there's a lot of interaction, and I wouldn't call it a safe space because it's completely out in the open, and there's a dynamic of, interaction between the community and the participants, which in itself is very valuable and provides all kinds of opportunities for sharing, having perspectives changed about what girls are capable of. And
I would imagine acceptance might be one of the things,
Yeah. So that is interesting. And then when we are doing the group sessions that are in a, more of just a room or setting, the safe space is definitely critical. I don't think that there would be much benefit if participants didn't feel safe when they came into the space. It's also something that we have to often insist on and sort of reinforce constantly, because just the fact that women and girls, their safety isn't really respected in their daily lives, and honoring that need to have solidarity among them, and recognizing what the issues are. All of the reason why we need that safe space is because it's not existing in other places in the community. So it's sort of a constant thing to remind participants of the fact that it is safe, and to remind community that this is a critical resource for them and that it needs to exist.
Thank you very much for that. We're getting towards the end of the panel. We have about 5-6 minutes left. that sort of time. And I wanted to just give each of you a chance to kind of help us to finish off the panel. Bernice, let me come to you first of all. What do you think is likely to be the next steps in the therapeutic dimension for the Friendship Bench? What are you looking for next, therapeutically, as we go forward?
The best thing we are looking at is leaving no one behind when it comes to receiving mental health talk therapy. So we just want to reach everyone, and we have started thinking about doing that through thinking of a handing over strategy to the Ministry of Health, because once we have handed over the intervention to the Ministry of Health, then it means our intervention can reach anyone in Zimbabwe. And the other thing is also to reach people in other countries as well, maybe through trainers from other countries, then also cascading the training to the other cadres, and also providing therapy to almost everyone. So the next dimension involves inclusivity, making sure that everyone from anywhere can receive talk therapy for free or in an affordable way.
Thank you for that. That's obviously an amazing goal. So I thought I should just turn very briefly to the Chief Operating Officer. Since your head of medical practice has spelled out what she wants to achieve, Lena, is that feasible?
Absolutely, because that's one of our priorities for 2024, where we're looking at developing a program strategy for effective handover to government. We've realized that as Friendship Bench, there's an opportunity for us to roll out the intervention through a blended approach. So we've recognized that Friendship Bench is the doer at scale, but we also recognize that we have limited capacity and resource to enable us to reach the last mile. So the next phase would be, partnering and empowering others to become the doer at scale. So like Bernice highlighted the strategy around handover to government, because we realize that government has the hardware, they have the infrastructure, and, with guidance, they're able to then, we're able to embed the Friendship Bench intervention into the primary healthcare facilities at urban, rural, looking at your district level. And so really getting down to the last mile. But also what's unique about the Friendship Bench intervention, just in terms of its adaptation, is that we're flexible enough that we can integrate mental health into existing programming areas. And so we've found that there's a huge demand for mental health services with HIV/AIDS, with maternal health care, with key populations, amongst the youth as well. So that flexibility and adaptability enables us also to reach a lot more community members that we ordinarily would not be able to do because of our resources. And so hence we've been able to then replicate the intervention beyond the borders of Zimbabwe. So, we're piloting with an organization called HelpAge in Washington, DC, the flexibility around that. And you talked about culture. So these are grandparents who've recognized the need to integrate mental health within their programming to assist the elderly. In Zanzibar, we're working with a group, and they've literally translated the Friendship Bench intervention into Swahili. So they call it Dawiti Rafiki, but they use men as delivering agents because of the culture component. And so HIV/AIDS in Malawi as part of research, in Kenya, in Vietnam. And we've actually also identified an opportunity of translating the intervention into languages. And so we've identified 100, but are currently pursuing translation into about 18 languages.
Excellent. Having worked in Vietnam, for example, I can see that would be very interesting, really interesting to do. Christina, looking at the way forward, of course, for yourself, but also thinking about the question of sustainability for the work that you do, for the intervention that you do. How do you view that?
I think one of the most sustainable ways forward is more the individual sort of discrete artistic activities, as opposed to the public mural making, as powerful as that is and dynamic and interesting. And yeah, I think that in these next couple of years, we'll have an opportunity to scale up, and we'll be able to kind of refine and learn more about the curriculum we're offering and how those activities, are they utilized outside of the sessions, and how are they utilized? So I think that's something that we're going to be working on and developing in the coming years as we have this opportunity to scale up. And one area that we want to grow more in, I mentioned our trauma-informed approach is more in the trauma-informed approach, because we have participants who have most likely experienced a traumatic event in their lifetime participating, and what we're offering is a social support network and self-regulation, but we're not offering that opportunity to deeply process trauma. And so being even more trauma-informed, I think, is important, but then also thinking about, is there anything else that we can offer to the participants beyond that, and or linking them to another resource or service, which doesn't really exist, but that's something we're thinking about.
I'm aching to put you together with the Trauma Resiliency Institution, because they are, so involved in that particular field, as we saw from the last panel. Just get a word from you, please. I'm afraid we have to give you 1 minute, but I know that you'll make the most of it. What about the future?
Chris, I think for us in the future, while we try and scale our existing programs, which we fund and run on our own, the idea is to fund existing programs, existing nonprofit organizations that are already doing good work, and collaborate and scale existing programs outside of Montauk's, and also to really try and invest a little more in scaling, capacity building existing professional networks. Because again, the number of professionals in India are definitely small, but the small number definitely needs a lot of upscaling that's more practical and beneficiary driven. So I think that's where Montauk's is headed, to make sure we're building capacity of the sector while we're building capacity of individuals by spreading awareness, and also then directly funding organizations that are already doing good work in mental health in India.
Thank you very much, and how kind of you to be so precise. Just to say that there's coming up now is a 15-minute break. And then after that, we welcome Leon Zeitz as our moderator with panel 3, integrating lived experience in climate change and mental health research and practice. We look forward to that in a minute. It just remains for me to say thank you, Bernice, very much, Christina, Disquette, and Lena, for a fascinating panel. And thank you for, on behalf of Glasswing and USAID and the Catalyst Mental Health Collaboration, for being our panelists today. All the best.
Thank you, Chris. Thank you, everyone. Bye.
Thank you, everyone.
Bye.